hope to try to do something kind of Jeopardy-like, but I never had a chance to get around to it. So I'm going to do just kind of an impromptu discussion about, or kind of almost like a quiz for cardiomyopathies. So give you a little bit of primer and kind of give an outline of how I'm going to discuss it today. Cardiomyopathies in kids are fairly different than cardiomyopathies in adults. So in general, when you think about cardiomyopathies, you think about three different types. You have dilated cardiomyopathies, hypertrophic cardiomyopathies, and restrictive cardiomyopathies. Those are the three kind of general topics of cardiomyopathies. We don't see a lot of restrictive. In my entire career of 20-something years, I've probably seen 2 restrictive cardiomyopathies. They're real unusual. You can see them in adults, a little more common in older adults, but it's real unusual in kids. So I won't spend hardly any time on restrictive cardiomyopathies other than just to mention it. Dilated cardiomyopathies are, of course, very common, relatively speaking, as far as cardiomyopathies are concerned. Dr. Gray, I think, talked to you all about some acquired heart disease, and she, in that discussion, discussed myocarditis, which can lead to a dilated cardiomyopathy. There are certainly numerous other causes of dilated cardiomyopathies, and it's by far it's the more common cardiomyopathy that we see in kids. And then the last of the 3 is going to be hypertrophic cardiomyopathy. We don't see an awful lot of that, but we do see some. That's where probably the most advances. I don't know. I guess in dilated cardiomyopathies we've seen a lot of advances in some genetic causes, but in hypertrophic cardiomyopathy, the advances in genetic diagnosis has been pretty tremendous over the past 15 years. There are multiple genes that have been now identified to cause or potentially cause hypertrophic cardiomyopathy. So there's been a lot of change in how we work those patients up. Treatment has changed over the years, but not tremendously. There's still only limited options of what we can do for hypertrophic cardiomyopathies. So I'm going to start with a couple of questions, a couple of quizzes. This will be things that are related to either the diagnosis, the treatment, or the outcomes of cardiomyopathies. And the first one will be about therapeutics. So this is a little bit of a historical question. So if anybody has an answer to this, they can unmute and shout it out. So what do leeches, bloodletting, and Lasix have in common with cardiomyopathy?
They take volume off.
They take volume off. That's good. So essentially, if you want to talk like a physiologist, they are preload reducers. They reduce preload. So back in if y'all have heard some of my lectures before on this, back in the old days when they used to have surgeons were barbers, they would go in and they would give you a good bloodletting. You'd reduce some of your blood volume, and if you had some kind of cardiomyopathy or heart failure, you'd actually feel better if you had your bloodlet. Now the problem is you then become anemic because you've lost all your hemoglobin in your bloodletting, and you eventually get worse. But luckily for the barber, you've already been paid, and the patient walked out and felt much better, and then they of course died of heart failure. But leeches, somewhat in the same way, they're not quite as effective as bloodletting because it takes a little bit more time. And then, of course, Lasix and diuretics are the more acceptable versions of preload reduction. The only other way other than diuretics to truly reduce preload, I guess you could say, is dialysis is a good way to do that if you can't get fluid off through your using your kidneys to get rid of preload. There are other ways to reduce preload with vasodilation, but that also gets into afterload reduction, so I won't mix that up too much. So that's good answer. So it kind of gets us into how do you treat, and I'll talk a little bit about how you treat and deal with dilated cardiomyopathies, and then we'll deal with some other ways of treating other types of cardiomyopathies. But dilated cardiomyopathies, there's three mechanisms for treatment. You can reduce preload, you can reduce afterload, or you can improve contractility. There's some debate about how beta blockers work in treating dilated cardiomyopathies as well. Reducing heart rate and remodeling are a couple of the mechanisms that potentially work with dilated cardiomyopathies and beta blockers. But I'm not going to get too much into that. That's really more of an adult kind of chronic heart failure treatment. So I want to get more into the acute therapy. First would be preload reduction. We talked about diuretics, and that's really the only way to truly do an isolated reduction of preload. There are other medications like the afterload reducers and venodilators that can reduce preload, but they also reduce afterload at the same time, so it gets a little confusing when you're talking about the physiology of it. So you have preload reduction with diuretics. Next would be afterload reduction. There's multiple different therapeutics that can reduce afterload. By far, the most commonly used is an ACE inhibitor. Calcium channel blockers do a fairly good job. IV milrinone is a fairly good afterload reducer, but the staples for kids is mainly we use ACE inhibitors. Calcium channel blockers have a bad kind of rap when you talk about kids, because in young kids and babies and infants, we don't use calcium channel blockers because some of them can have cardiovascular collapse with calcium channel blockers and react poorly. But in older kids, calcium channel blockers work pretty well. But in general, in pediatrics, we'll use afterload reducers like enalapril, lisinopril are the most commonly used ones, because they are, at least enalapril is now available as a liquid, so it's usable in little kids who need liquid medications. So the first line of therapy I tend to use in a dilated cardiomyopathy is preload reduction, and then we follow it fairly quickly with afterload reduction as they can tolerate it with their blood pressure. And then the last is improving contractility. Of course, the only medication we can do that with orally is digoxin. Digoxin is a very old drug, not used as much as it used to be, but still a very useful therapeutic, both from an antiarrhythmic and from a improved contractility standpoint. It doesn't do a tremendous job in improving contractility, but does some. If you really are dealing with an acute case of dilated cardiomyopathy and heart failure, you really want to deal more with IV inotropes, like epinephrine, norepinephrine, and all the other inotropes that we use IV. Milrinone is a very good drug for treating heart failure acutely, mainly because it both reduces afterload and does help improve contractility. So it's also very useful. So that's kind of the three arms of therapy of treating a dilated cardiomyopathy. So let me think of another quiz question. How about tell me a therapeutic for treating hypertrophic cardiomyopathy that led to the career collapse of a famous, I guess relatively famous, NIH investigator because of fraud in his reporting of data. What therapeutic that we don't use much anymore that was once used to treat hypertrophic cardiomyopathy that fell into disfavor because of some falsification of the outcome data? Lots of silence out there. It's something we don't talk about much anymore, but pacing at one time was felt to be a fairly effective mechanism for improving hypertrophic cardiomyopathy. And the reality is it probably in some patients does work. And you wonder why, cardiac pacing would make any improvement in heart failure or in treatment of hypertrophic cardiomyopathy. But there was an investigator at NIH who was the main instigator of this, who was looking at if you pace the ventricle, especially the left ventricle, and you pace it and you put the pacemaker leads that cause ventricular contraction at the apex of the left ventricle, and you cause the contractions to occur from the apex up to the base of the heart, then you get all the blood out of the apex of the heart before the outflow tract collapses or contracts. So you change the contraction dynamic of the left ventricle and, in theory, reduce the outflow tract obstruction. And in reality, it does work in some patients. The problem is, and I don't even remember the name of the guy who was the investigator, he used to be fairly famous in cardiology circles, but he falsified some of the data that he had and made it look like it was a little more universally helpful in treating patients. And after it was discovered that his data was falsified, there was then questions about whether any of the data was worthwhile. But I actually have had several patients early in my career who got pacemaker implantation and actually did fairly well, had significant improvements in their left ventricular outflow tract obstructions, and actually improvement in symptoms as well. So we don't tend to use pacing as much, mainly because it's not as effective universally as in other therapies are, but it's still something we use. So treatment of hypertrophic cardiomyopathy is very different than how we treat dilated cardiomyopathy. You essentially have a hyperdynamic outflow tract obstruction in the left ventricle is the main pathology that we're dealing with, that we try to treat when we're dealing with hypertrophic cardiomyopathy. Majority of patients who have hypertrophic cardiomyopathy, we try not to actually treat them. You're only typically going to treat the patients who are symptomatic. If you try to go after treating risk of sudden death and echo numbers for outflow tract obstructions, you don't tend to get great results, and you tend to get better results if you're treating a symptomatic patient. These are patients who are short of breath or have syncope with exercise, and those are the ones you tend to get better results with. But there's multiple ways of dealing with treating hypertrophic cardiomyopathy, and the big strategies are to either try to eliminate the thickened muscle in the left ventricular outflow tract to improve the obstruction, or decreasing contractility of the left ventricular outflow tract and hopefully decreasing obstruction. So those are the two general strategies for treating hypertrophic cardiomyopathy. I'll talk first about getting rid of the obstruction, physically getting rid of the obstruction. There's several ways to do this. The most common way and the oldest way is surgery. You can essentially carve out the muscle. So you have to open up the aorta, go through the aortic valve, and carve muscle out of the left ventricular outflow tract. You try not to make incisions into the left ventricle if possible, because of the arrhythmogenic potential of that. But that is something that you can do if you have to. But surgery to eliminate the obstruction is one way of doing that. Another way to eliminate that obstruction and to try to get rid of the thickened muscle is something called septal alcohol ablation. It's been used varyingly over time as to how frequently it's used and how effective it is. Some patients are very good candidates for it, and some centers still use it. It's much more commonly used in Europe than it is in the US. But essentially what you do is you thread a catheter into the muscle that's hypertrophied in the left ventricle, and you inject alcohol, ethyl alcohol, drinking, regular old stuff. Vodka essentially is what you shoot into the coronary. And essentially what this does is it kills the myocardium that is perfused by that coronary. Once you kill that myocardium, it tends to not the hypertrophy tends not to get worse and can get better. You can actually see thinning of the heart muscle in the area that you inject. And also that heart muscle does not contract anymore. So it kind of is a combination of decreasing contractility and getting rid of the actual obstruction. So it's a somewhat of a combination therapy. And it has been shown to be very effective in some patients. It is very user dependent. There are some people who are very good at it, and some people are very good. And also the patient selection is very important. Some patients, because of their anatomy, just does not work very well, and other patients it does. So you really have to select the patients very well. But there are still institutions that believe in this and do this, and it is a therapy that is still out there for possibilities. So those are the two main ways of getting rid of the obstruction. In theory, transplantation is a way of getting rid of the obstruction. I think that's somewhat of an excessive hyperbole of how to eliminate obstruction, just replace the heart, but it truly does. So that is a therapy that we certainly are still using in patients who have hypertrophic cardiomyopathy. The other way is to try to reduce contractility. The main ways of doing this is beta blockers and calcium channel blockers are the best for doing this. So beta blockers in fairly high doses, and then calcium channel blockers are also very effective in the same way. You can see improvement in symptoms. You can see improvement in outflow tract obstructions. Of course, you also in these patients have to restrict their activity, because activity increases their heart rate, increases the contractility of the heart, and makes the obstruction typically worse. So in all those therapies, you can improve symptoms. The major symptom we worry about in hypertrophic cardiomyopathy is sudden death. And the only therapy that we know reduces sudden death is implantable defibrillators. So intermixed in all of these therapies for hypertrophic cardiomyopathy, we think about risk for sudden death. And again, the only intervention that's ever been proven to reduce sudden death is implantable defibrillators, because the majority of these patients, their sudden death is related to ventricular fibrillation. Hearts that are very hypertrophied and outflow tracts that are very obstructed, even if you have a defibrillator in, you don't necessarily save their lives, because their obstruction can be so severe that they may not recover from an event of ventricular fibrillation, but we do know it will reduce the risk. So you kind of have to overlay that into all these. So most patients who get surgery also get a defibrillator. Most patients who get alcohol ablation also get a defibrillator. And some patients who don't get either of those therapies or are just treated medically will have implantation of defibrillator, especially if they have a history of VTAC, or they have a lot of ventricular ectopy on their Holter monitor, or they've had an event of near sudden death or syncope that is felt to be related to arrhythmia. So those will be the indications for defibrillator implantation. Short of that, you can do home defibrillators for people now. You can have a defibrillator at home or at school for the patients. If you really feel like that's an indication, then you probably ought to be thinking about an implantable defibrillator, because you've got to have someone around to do a defibrillation if you have a home external defibrillator. So if you're thinking about it, you probably need to consider implantable defibrillators unless they have some kind of contraindication to that. So that would be a consideration for that. So those are the big therapies for hypertrophic cardiomyopathy. Restrictive cardiomyopathy, since I brought it up as one of the potential cardiomyopathy types, really the only treatment for restrictive cardiomyopathies is eventual cardiac transplantation. So the few patients I've had with restrictive cardiomyopathies, one has been transplanted, one actually died, and one I think is still on the transplant list. So those are considerations for restrictive cardiomyopathies. Not a whole lot you can do physiologically to improve restrictive cardiomyopathies. You can treat their symptoms a little bit, sometimes with preload reducers, but it doesn't tend to work very well. So another question for you. This is kind of a what am I thinking kind of question, but hopefully you'll catch the gist of it. We've talked about therapeutics for dilated cardiomyopathies. We've talked about therapeutics for hypertrophic cardiomyopathies. So which, I guess you could say, which which therapeutic for dilated cardiomyopathies is contraindicated in most patients who have hypertrophic cardiomyopathies because it actually can worsen their symptoms and increase the risk of sudden death. Anybody? What
Diuretics.
therapeutic? Diuretics, very good. So you don't want to decrease preload in patients who have hypertrophic cardiomyopathy. If you think about it, the heart needs to fill with as much blood as possible, the left ventricle does, so that the outflow tract does not collapse during systole as much. So if you take away preload, you're going to make your obstruction worse and potentially make your risk of sudden death worse in hypertrophic cardiomyopathy. So when you've got a patient who's come into the unit with a history of hypertrophic cardiomyopathy and they've had a syncopal event, what you think about is giving them volume, giving them fluid, and you want to avoid giving them diuretics if possible. Now, if you've got something else going on that they require diuretics for, that's a whole nother story. But in treating their symptoms and treating their outflow tract obstructions, avoid volume depletion and avoid preload reduction. So yes, that's probably a no-no. Afterload reduction is probably not a great thing for hypertrophic cardiomyopathy, and probably not going to do a lot for you, but it's not going to be as risky as using diuretics. Can anybody think of any other acquired cardiac conditions that Lasix would be a almost severe contraindication? That giving Lasix can cause sudden death if given to a patient with another acquired cardiac
prolapse.
You probably would like to avoid it in prolapse because you need volume in mitral valve prolapse, but unlikely to cause any untold harm. What else?
What was the rest of your question? Sorry, we jumped the gun.
So acquired heart disease that you do not want to give Lasix in. To make it even more convoluted, a mild case of this, you could probably get away giving Lasix, but a severe case, Lasix would be contraindicated.
Would it be myocarditis?
No. So it's pericardial effusion. No, it's pericardial effusion.
Oh.
If you have a severe pericardial effusion and tamponade, and you give diuretics or you reduce preload, you can collapse the heart because the pressure in the pericardial sac is pushing on the outside of the heart. And if you take away the atria and the ventricle during diastole, for that matter, if you take away that preload or that pressure before contraction, the heart can literally collapse under the pressure of the pericardial effusion or the tamponade. So whenever you're dealing with a big pericardial effusion, you always want to figure out where you are in that curve of how high the pressures are in the pericardial sac. And if you see a patient who's got a big pericardial effusion and there's evidence of atrial collapse, actually giving fluid to hold the heart open is much more important. And you want to avoid dropping their preload with diuretics. The course of treatment for pericardial tamponade is what? What's the only real therapy for treating tamponade?
Pericardiocentesis.
Yes, stick a needle in it. So we don't stick a lot of needles in hearts and pericardiums, but you do need to do that for a tamponade. Any of y'all watch the series Transplant? It's about an ER in Canada. It's on NBC now.
Nope.
It's actually fairly good if you haven't watched it. If you can go back
Liz Beatty has watched it.
I like the main character because he is a transplant. He's actually an immigrant from Syria, and really likable main character. He's got all kind of history that he deals with, but it's a really good show, and the medicine's decent. we all watch these medical shows and we criticize them and because their medicine's really bad. The medicine in this is actually pretty good. Of course, they have ER doctors treating all kind of stuff all over the hospital. I don't know why they don't turn it over to the surgeons and the ICU physicians, but that's a whole other story. But they did a pericardiocentesis on the last episode I watched, and he did it with a needle. And needle pericardiocentesis is very, very dangerous. You really want to have a catheter. I've had one patient of mine who at another institution had a pericardial effusion, and they did a needle pericardiocentesis and left the needle in as they extracted fluid. And as the fluid went away, the heart got closer and closer to the needle, and it lacerated the outside of the heart and the coronaries on the outside of the heart. Very dangerous to do. So if you do a pericardiocentesis, you need to exchange it for a catheter before pulling the fluid out. Now, of course, if someone is coding and near death, then you just do what you got to do. But don't leave the needle in when you do a pericardiocentesis. Always exchange it out for a catheter if that can be done. But other than that, the show is actually pretty good, and I recommend you may want to watch. There's a pediatrician on the show, and he does some relatively appropriate stuff in treatment of kids. So those are treatments for dilated, hypertrophic, and restrictive cardiomyopathies. I think given my late start and the impromptu-ness of my lecture, I'm going to cut it off there unless there are any questions so that we can all get back to our work. Any questions from anybody about those treatments?
I don't think so. Thank you.
All right. Everybody stay safe. We are on a countdown to vaccine. So if we can just stay healthy for another few weeks, we might get vaccinated. So don't let your guard down. Be careful and have a good week.